Dear ladies and gentlemen, I am going to demonstrate my technique of microcoaxial cataract surgery with Stellaris. My first incision is paracentesis located at 12 o'clock. It is followed by intracameral injection of 1% lidocaine. Viscoelastic is injected starting from the distal part of the anterior chamber. By slowly retracting the cannula, I am filling the chamber completely. A clear corneal single-plane temporal incision is made with this 1.6 by 1.8 mm trapezoidal metal blade. I prefer to initiate capsulorhexis by puncturing anterior capsule with the forceps. Then I grasp the flap and pull it in the clockwise direction to form capsulorhexis approximately 5.5 mm in diameter. I prefer this special capsulorhexis forceps that works very well with microincisions. A small wound works as an oarlock, restricting surgeon's movements. You can see the eyeball moving together with the instrument. To complete the continuous capsulorhexis, capsular flap is usually regrasped 4 or 5 times. Finally, the rhexis is done. With 25 gauge cannula, I go right under the edge of the capsule. During injection, the fluid wave can be observed. Then I slightly depress the nucleus to drain BSS from the retrolenticular space and rotate the lens. I will be using the special Stellaris handpiece designed for 1.8 mm microcoaxial phaco. My preferred technique is a quick chop. The needle is embedded into the central part of the lens. The nucleus is fixated with high vacuum and chopped into 2 pieces with the help of the second instrument. Then the lens is rotated 90 degrees and chopped again. My preferred settings are vacuum 450 mm of mercury, linear ultrasound, ultrasonic power 30%, 80 pulses per second, and bottle height is 100 centimeters. I am not making any grooves. That's why there is no need to change my settings during the procedure. The phaco tip is located centrally in the deepest part of the anterior chamber. The chopper helps to rotate and bisect the nucleus and guide the fragments towards the tip. This particular needle-sleeve combinations provides perfect flowability and absence of fragment repulsion. These are the final steps of nucleus removal. A dual linear foot pedal gives me additional options to control and balance the power and fluidics. The centrally located air bubble shows favorable hydrodynamic environment near the corneal endothelium. The coaxial IA tip allows me to effectively remove cortical material with 550 mm of vacuum. A second instrument is stabilizing the globe and assisting the IA tip. I reserve bimanual IA technique only for small pupil phaco cases. This curved tip is very good in approaching cortex material even in subincisional area. Viscoelastic is injected to fill the chamber and expand the capsular bag. This is an aqueous MI60 aspheric implant. Now it is positioned into the cartridge filled with viscoelastic. Then the cartridge is connected to the disposable injector. I prefer to do all steps under the operating microscope. Now the lens is being implanted through the unenlarged 1.8 mm incision. A wound assistant technique is used with side port instrument causing contraction. The surgeon can feel some resistance while the lens is moving through the injector. When the implant enters the anterior chamber, it unfolds very slowly. Then I guide the haptic elements in place with the second instrument. I am going behind the lens with the IA tip and aspirate viscoelastic from the bag. As a second step, viscoelastic is removed from the anterior chamber. I am always hydrating my incisions with balanced salt solution to achieve water tightness. Then I check the leakage with microsponge. And now you can see the case is completed successfully. Thank you for your attention.